This presentation is about the radiographic changes that we see in glioblastoma following a corticosteroid dose change. This article is currently under review and may be accessible in a couple of weeks or months under this title, probably. So contrast-enhancing tumor volume is a well-known radiographic surrogate of glioblastoma burden. We saw from histology, from historical articles, that the enhancing areas of the tumor are the ones that are more malignant on histology. We know that pre- and post-surgical volumes of enhancing tissue predict survival in glioblastoma, and that the longitudinal changes in terms of shrinkage and enlargement of enhancing tissue also is linked and predict survival. This is why, mostly for clinical trials, but also for clinical practice, we mainly track the changes in the volumetric changes of the enhancing component to understand whether a lesion is responding to a treatment or is progressing. On the other hand, ADC from diffusion MRI is a macrostructural biomarker. It's been shown to be helpful for differential diagnosis of brain tumors, to profile the molecular subtypes of gliomas, and to stratify prognosis of glioblastoma and predict treatment response in some specific cases. The issue with these two, one of the issues with these two biomarkers, meaning the contrast-enhancing volume and the ADC from diffusion, is that corticosteroids can change their values. It can cause an apparent shrinkage of enhancing volume, or it can cause a diffusion restriction. And there is lack of quantitative data about this phenomena. For instance, RANO2 for clinical trial response still requires a 40% volumetric increase to define progression, even in cases where there is concomitant corticosteroid increase, which cause allegedly shrinkage. And ADC evaluations almost never correct or adjust for corticosteroid administration. So quantifying these phenomena and keep starting to create benchmark values of how much shrinkage and diffusion drop we're expecting with corticosteroids, it's important because we could redefine criteria for disease progression in case of corticosteroid administration. And we could interpret ADC more accurately if we know these phenomena. So what we did is that we retrospectively looked at treatment-naive glioblastoma with multiple pre-surgical scans, typically 2, most of the cases, and we divided pairs of scans where corticosteroid dose was increased and cases where the corticosteroid dose was maintained stable. All of the increased corticosteroids started from 0 in our course, so it was 0 to a certain increased dose, whereas stable cases, almost all of the cases were 0 and 0 both time points, so no corticosteroids, but some of the cases were at another, like a very small minority was on stable corticosteroids. We segmented the enhancing portion of the tumor and we extracted volumes and ADC values. We reported both the observed values of enhancement, volume shrinkage, and ADC changes, but also we ran a multivariate regression to model the volumetric changes while adjusting for an estimate of tumor growth between time points. So first, representative cases, as described before and as we were expected, we see that the enhancing tissue after corticosteroids becomes thin, like the nodular components shrink down, and this is what we decided to call a pseudo-response just because it's very similar to the bevacizumab pseudo-response in terms of appearance and mechanism. And for diffusion, what we see is that areas of enhancement on diffusion, they do show diffusion restriction after corticosteroids. Interestingly, when we see pseudo-response, it's still possible that there is tumor progression elsewhere or mixed response. In terms of quantitative data, we see that the increased corticosteroid group had a overall shrinkage of the tumor, whereas the stable dose had a growth, which makes sense for the natural history of the disease, which is pre-treatment bound to grow. You can see the different trajectories of the two groups. But these overall 23-24% shrinkage in the increased group it's confounded by the fact that there is also interval tumor growth. So with a multivariate analysis comparing the two groups and adjusting for time interval between scans, we modeled the corticosteroid-induced shrinkage and estimated that it could be around 44%, a minimum of 26%, with some assumptions. In terms of diffusion, we saw that the increased dose of corticosteroid group had a diffusion restriction with a decrease of 180 median units, which corresponded to around 14%, whereas the stable dose did not have a significant change from baseline. Overall, we are trying to characterize, hopefully more studies will add more data to have a quantitative estimate of the shrinkage induced by steroids and diffusion drop induced by steroids. The round application is that if we know what is the shrinkage that is induced by corticosteroids, we could adjust thresholds for progression in case of corticosteroid dose increase and not expect 40%, just like cases on stable corticosteroids. In terms of diffusion applications, the diffusion values could be interpreted more accurately if we know how much the corticosteroid changed those. This article is currently under review, and you could read it hopefully in the next weeks, months. And thank you, and thanks to all my collaborators for helping.